A young boy presents with lesions as shown. He has been having this lesion since birth. A doctor tries to burn it with cautery, but the lesions recurred. Pick the true statement. Look at the image. This image is of what we call as a melanocytic nevus. See the name, melanocytic nevus. Okay. Now melanocytic nevus is what? It's commonly referred to as the mole. It's referred to as the mole. Now what mole people call as are basically birthmarks, right? Though moles can happen later in life also, so that is called acquired melanocytic nevus. But the question says since birth, so that is a congenital. So we'll put C, which is congenital melanocytic nevus, also called as CMN, which is commonly referred to as the birthmark or the birth mole. It's often used as an identity mark in many forms and many exam forms. You'll call that as something that stays with you. So CMNs don't really disappear. They stay with you throughout life. So that's why it's used as an identity mark. Now, the question is what is to be done about it? Now, somebody has burnt it up with cautery. Cautery is a burning technique where you fire some electric material, electric current, and this current will just kind of try to destroy those accumulated melanocytes, right? Now, the problem with CMNs, many of them are not only epidermal, there's a little bit of a dermal component to many CMNs. Now, because of the deep component, many times what happens is if you burn it, many times you just burn the top off. Mean the epidermal component can be burnt off, but the dermal component remains, and that might give you a relapse. So many times it recurs back. Now, when it recurs, the patient worries about a malignancy being the cause of recurrence, but no, it's recurred because of inadequate removal. And if a doctor says, okay, let me remove the full thing, let me just go down into the dermis and remove the whole scoop. The problem is once you touch the dermis with an electric current, you might create a scar. So the problem with complete removal is scar formation with a cautery technique. So that's why most doctors will underdo it to prevent a scar formation, and when they underdo it, only the epidermis is removed, and that increases the chance of recurrence. And that's why the question says it's recurred. Now pick the true statement. Biopsy needs to be done for malignancy. No, not true. CMN is a benign lesion. Only if the CMN is giant CMN. Okay. Giant CMN is defined as more than 20 centimeter size. Then you would worry about a malignancy, that too in very low proportion of patients. So this is such a small mole, so there's no chance of malignancy. So recurrence is not a sign of malignancy, it's a sign of incomplete removal, right? Aggregation of melanocyte is expected, that is obviously correct. The melanocytic nevus, the name itself means it's aggregation of melanocyte in one spot. Aggressive management required? No. In fact, when you aggressively do it, you scoop out the dermis, as I said, then you would create a scar formation. So many times on face, CMNs many times come on the face. People remove it for cosmetic reasons, and when they remove it for cosmetic reasons, what if the doctor creates a scar at that position that in fact looks worse? So in fact, we would always want to underdo this, not overdo this, and many doctors will in fact tell the patient to accept what they have, not really fiddle with the cautery. Now there are lasers now which are being done, but sometimes again lasers might not be able to remove it completely. So it's a tough thing to remove. So many times we just ask the patient to accept what he has, but if you want to do something, we can do a laser on this. Sun exposure as a role? No. There's no relation of sun to this melanocyte aggregation. It's just a nevus. It's a collection of melanocytes since birth. Okay, so the answer to this would be the second option. Second question now. A patient present with asymptomatic hypopigmented lesion on chest and back. His Woods lamp is as shown. What we want to see in this Woods lamp? A Woods lamp is obviously something which will be giving us a color. Okay. Now this color which you can see is a faint yellow color. Okay. Faint yellow color is what is mentioned here. Now when you say asymptomatic and hypopigmented lesions on the chest and the back with a faint yellow color, we would put 2 and 2 together and we will call this disease as pityriasis versicolor. Now pityriasis versicolor is basically a disease process which is caused by a fungus called as Malassezia. Now Malassezia is very traditionally going to be a disease in the areas which are mentioned, which is the chest and the back. Very small hypopigmented lesions will be coming. So Malassezia typically creates hypopigmentation. Remember, it does not create depigmentation. If the question would have said depigmented, you would think of vitiligo, but hypopigmented would make you think of pityriasis versicolor, or something like Hansen's also is hypopigment on the back, but Hansen's Woods lamp is not positive. So we would not want to think of Hansen's here. Okay, so hypopigmented on the chest and the back could either be, see this, PKDL, which is post-Kala-Azar dermal leishmaniasis, it could be Hansen, or it could be pityriasis versicolor. That is what you would think of first up. Now Hansen would usually be anesthetic or hypoaesthetic. Okay, so it would not be asymptomatic, so this is gone. So you would think of PKDL or Petrus versicolor. Now PKDL is negative on Woods lamp, okay, whereas Petrus versicolor is positive on Woods lamp. So then this Woods lamp positivity would again make you point towards Petrus versicolor. So that is the answer here. Let's look at the true statement which needs to be picked up. Autoimmune disease, no. Versicularism, malaise is an infection issue, right? Smear would help in diagnosis, correct, because you would want to do a potassium hydroxide mount, which would typically give you something called as spaghetti meatball pattern. Spaghetti meatball pattern. Spaghetti means these linear filamentous lines, and meatballs are these circular elements. So spaghetti and meatball pattern is typically the pattern of pityriasis versicolor, okay, which is what you would want to do. Greasevolin would help in resolution, no. You would want to give a azole group of drugs for Petrus versicolor, like ketoconazole, fluconazole, itraconazole. Greasevolin does not work. Biopsy not required. For such a simple Petrus versicolor, you just want to do a scraping of those scales which are there on the Petrus versicolor lesion, and you would want to do a spaghetti meatball demonstration on a KOH mount. Third question. A young male comes with lesions all over his body since 15 days. On examination, erythematous, papules and scaly lesions are noticed on his trunk and limbs as shown. He is not experiencing any symptom. He also reports perianal lesions. What is the next investigation? Now, have you realized that in this CBT there are a lot of these clinical vignette kind of questions. Now, when you have clinical vignettes, you would have to put 2 and 2 together. For example, you remember the Petrus versicolor question? There was some clinical mention, some Woods lamp was also mentioned. So you have to put 2 and 2 together. And what was the question? What was the options about? Smear, which is microbiology. Greasevolin, which is pharmacology. So there's a clinical thing. There's an investigation of Woods lamp. There's microbiology thrown in there. There's a pharmacology thrown in there. So in fact, you would then be tested on 3 or 4 separate things. That's what is really the way the questions are being framed right now. Okay. In fact, when we are watching, in fact we watch the MCI exams also this time, the more and more clinical based questions are now coming, and NEET is also almost like AIIMS exam now, where a lot of these clinical stuff is coming. So that's why these questions prepare you for that scenario. A young male, the moment it's a young male, we would kind of in our mind look at sexually active. That's just a way of saying that. Lesion over his body since 15 days, erythematous, papules and scale. So it's a papulosquamous lesion. Okay. Now what do you mean by papulo is papule, squamous means scale. So any disease which is papule and scale is called papulosquamous. Alright. Trunk and limbs as shown. Now can you see this? Scaly lesions on the sole, right? And they're asymptomatic, so these are non-itchy is what we would be gathering, and there's some perianal lesion. Now if you put everything together, so there's some asymptomatic lesions on his trunk, okay, there's some lesion on his foot, for example, which are asymptomatic. Now this almost looks like psoriasis, which is like silvery scale and all that on the foot, but psoriasis would be itchy, so you would not think of psoriasis. So we have something which is called the Great Mimicker in dermatology. Okay, the Great Mimicker means there is a disease called as secondary syphilis, which mimics psoriasis, which mimics so many other diseases. And the classical thing about secondary syphilis is it is asymptomatic. It happens in young individuals who are sexually active. Now the perianal lesions which were mentioned is possibly condyloma lata, which are perianal plaques. So if you put 2 and 2 together, asymptomatic lesions on the sole, on the hands, some asymptomatic truncal lesions, some perianal condyloma lata, young male. So you have to put a lot of things together to be able to get to a diagnosis. It's not a direct question. Do you get this? Now it's a deliberate ploy for us to give you these uncomfortable questions. Now you might know everything about secondary syphilis theory wise. Still you will find it a bit difficult in putting 2 and 2 together in this question, right? So this is the skill I want all of you to learn. Okay. Now what is the next investigation? For secondary syphilis, the best one is VDRL. VDRL is almost always positive in people with secondary syphilis. Biopsy, not the first step. KOH, obviously not. Urine for microscopy, no relation. So you want to look at VDRL, which is positive in everyone with secondary syphilis. Let's look at the fourth question. A patient of recurrent type 2 lepra reaction is on treatment. She now reports darkening of her skin. Now can you see the darkening of her skin here? Red brown color, red brown pigmentation. Okay. Now there is a drug in the MDT regimen called as clofazimine. Now clofazimine is actually the recommended WHO drug for recurrent type 2 lepra reaction. Now in recurrent type 2 lepra reaction, we do that in the theory in the classes as well. You want to give clofazimine. Now earlier we used to give thalidomide, but thalidomide has side effects. So then WHO withdraws its support to thalidomide and gives it to clofazimine. You cannot give steroids recurrently, okay, for a type 2 lepra reaction. So there is something called as recurrent type 2 lepra reaction. Okay, there's an entity like that. Meaning type 2 keeps on coming again and again. ENL keeps on coming again and again. Now if there is 1 or 2 episodes of ENL in the beginning, you can give steroids. But if there's 5 episodes, 6 episodes, 7 episodes, you can't give steroids. They have side effects. So then you want to give clofazimine for those people. The problem with that is clofazimine makes the skin very dark. So it's a cosmetic issue that people have with this drug, and that's why we want people to know that this drug is, but it's temporary. It will give you a bit of darkness and hyperpigmentation. Ultimately it will be okay, but only after stoppage of the drug. So answer on this would be clofazimine. Clofazimine is the answer that you would want to mark here. Okay, an 8-year-old child presents with localized alopecia of the scalp with scales. Now when it's a child, so the first thing you need to know, child with alopecia, immediately you should think of a disease called as tinea capitis. It's a very classical thing I want you to think of. Alopecia in a child, though there can be many things, but uppermost in your mind should be tinea capitis. Tinea capitis is also scaly, and that scaly tinea capitis is called as a grey patch. There's a type of tinea capitis called as grey patch tinea capitis, which is basically scaly and itchy and usually easily pluckable hairs. Okay, easily pluckable hairs. Because of this easily pluckable hairs, they'll have alopecia, and that is what the question mentions. So you would call it tinea capitis. Why not alopecia areata? This is also localized alopecia, so that is correct. But there is no scale. Remember this. It's always a very smooth patch of alopecia. There's no scale, so you would not want to think of this. Trichotillomania is usually in young females. It's not in a child. Usually, young females who tend to pull on the hair. Okay, and there is only partial alopecia, not a complete alopecia, and no scales. And usually there is going to be some kind of indication of a picking behavior, like a psychiatry issue or something of that sort would be mentioned, which is obviously not mentioned. Lichen planus will usually have a scarring alopecia, okay, and again no scales. So this scale is an important word in this question. Scaling is usually for tinea capitis, because tinea anyway is scaly. Now we do that in the class also, annular scales in tinea. So tinea is defined by scales. Question number 6. A 60-year-old patient comes with the following nail changes. Pick the correct statement. Now what I want you to see here is you can make out some yellow color, yellow nail plate. Yellow nail plate, especially on the edges. Can you see it's on the edge? So if I draw a nail, okay, this is the nail, let's say. If that yellow color is here, see where I am drawing. See this on the edge, right? And this is a typical position for this nail color. The disease is onychomycosis, also called as tinea unguum, which is fungal on the nail, dermatophytic infection of the nail. Typically gives you yellow color on the edge of the nail. Now pick the true statement. Now tinea unguum, okay, which is Trichophyton rubrum, is the commonest cause of, most common cause of all tinnias except tinea capitis. You should know this, that in India the commonest cause of all tinnias is Trichophyton rubrum, apart from tinea capitis. For tinea capitis, the commonest organism in India is Trichophyton violation. Okay, so but usually it's Trichophyton. So mycosome will be the commonest cause, is incorrect. Extensor elbow plaques are expected? No. Extensor elbow plaques is suggestive of psoriasis. This is not psoriasis, this is fungus. Oral terbinafine is the drug of choice, correct. For all tinea, drug of choice is terbinafine. Okay, and for all tinea again except tinea capitis. For that the drug of choice is oral griseofulvin. So you just remember that tinea capitis is different. Organism is Trichopatin violatium, drug of choice is griseofulvin. So everything is different. But for the standard tinea you want to give terbinafine. Associated with alopecia, not necessarily. Okay, it's not that everyone who has tinea unguum will have tinea capitis. No, it's not like that. Okay, because the organism is many times different. So terbinafine is the best answer on this. Alopecia, not necessary. In fact, onychomycosis is usually going to be seen in adults. Okay, and adults don't have tinea capitis. Tinea capitis is a disease of children. In fact, that is why the best answer would be terbinafine here. Okay, look at the 7th question. We may have missed it. Kibnus phenomenon is not seen in. Now, what is Kibnus? Kibnus is basically a linear extension of lesion on scratching. So if there's one lesion like this, you scratch it, you will have new lesions coming in the line of the scratch. That's called Kibnus response. Now, the exact etiology of Kibnus is not really known, but it may have something to do with immune disturbances in the scratch line. Now, molluscum is a virus which definitely has a Kibnus. So if you have one molluscum with an umbilication, on scratching you would have new lesions coming in a straight line. Darius is a rare cause of Kibnus. Darius is basically a congenital disease of calcium ATPase mutation issue, and that gives you hyperkeratotic papules, and then linearly when you scratch sometimes you can have increase in the line. LP is an autoimmune disease which has very classically a Kibnus phenomena. Now LP is an itchy lesion, so you want to tell the patient not to itch too much, otherwise you will have new lesions in the scratch line. Now contact leukoderma has no Kibnus response. In fact, Kibnus is seen in one more autoimmune disease called as vitiligo. That has Kibnus, but contact leukoderma, which is an external agent triggered whitishness. For example, somebody wears a slipper, get a V-shaped depigmentation in the slipper contact line, that's called contact leukoderma. No chance of that having a Kibnus. Even though it looks linear, that's not linear because of scratching, because of trauma. That's linear because the slipper shape is that way, and that's how you would want to look at the difference between that which looks like Kibnus, but no, it's not really a Kibnus response. All right, thank you very much. Now we would say goodbye then on this. Okay, question number 8. Lesions occur on the palm and the lip since 5 days as shown. The diagnosis for the left side image would be, now what I want to see is, look at this. Can you see grouped vesicles? And this would be suggestive of herpes labialis. Herpes labialis is a grouped blister on the upper lip. Okay, and this, can you see it's a target lesion? And where? On the palm and on the palm. So that's an acral lesion, right? So a target lesion would be suggestive of erythema multiforme, EM. The most common cause of EM is HSV type 1, and that causes herpes labialis. So can you see HSV connects both of these images? HSV1 connects herpes labialis to erythema multiforme. So in fact, the commonest association of EM is a patient who's got herpes labialis. So many times people have herpes labialis blisters here, and they can come with a lot of these palms and soles getting these target morphology lesions. So that is what the association is. This was actually a DNB question which came. So again, can you see the relation, the correlation that you need to do? I understand that some of these questions can be tough, but don't get discouraged by it. It's a deliberate ploy from us for you to, in spite of knowing theory, we want you to struggle to get the relation. And that's the skill I want you to develop, because a lot of times what happens is, you know the theory pit pat. You know the theory that the most common cause of EM is herpes. But then can you see in images? Just knowing that is not enough. You have to apply it into an MCQ, and that's what this CBT is attempting to do. Now the diagnosis left side image is erythema multiforme. On the left side image is erythema multiforme triggered by HSV1. Now fixed duct eruption would usually be a lip or a genital blue-gray color. Okay, and we are not looking at herpes labialis there, for example. We would look at more of the diarrhea episode, for example, which would be there in this situation. Now, for example, people take ornidazole or tinidazole, something like that. Pemphigus vulgaris will have oral or genital mucosal ulcers and blisters. Okay. Stevens-Johnson syndrome will usually have targetoid, not target. Targetoid means two-zone lesions. Also mucosal involvement. Okay, and usually a drug intake. All this would be mentioned. Something like anti-epileptics or sulfa group of drugs would be mentioned. So that's also again not mentioned. So we are not looking at this. So this is classically EM triggered by HSV.